the Progressive Podiatry Project, here to share knowledge, insights and information for you to improve your clinical practice and, most importantly, help you help your clients.
Welcome back to another episode of the Progressive Podiatry Project podcast. My name is Jackson Tisdale and with me is Talysha Reeve, and we're super excited this week to be launching the Plantar Fasciopathy Masterclass online course. To find out more about that, head to progressivepodiatryproject.com/PF Masterclass. It looks really good. I've been through it myself. Talysha's put a lot of hard work into it and it is absolutely fantastic. Off the back of that, we're going to go through a few of the key sort of points that we really want to, or we feel is really helpful to understand about plantar fasciopathy today, and with a few key questions that I'm going to direct towards Talysha. First of all, how you doing, Talysha? How's the work nerd brain going after off the course?
It is exhausted. Because it's been 12 months since we launched the exercise therapies course, I think I forgot how much your brain is just completely fried by the end of it. It sort of flashback to final year uni when you're cramming for every single exam, and it's just that cognitive overload. So this week, very much enjoying just chilling out because my brain is tired. But the launch went really well. We've had, I think, well over 50 people sign up already, and the feedback that's coming in is actually quite good. So I'm pretty stoked with it, and yeah, could talk about plantar fascia all day, every day.
We could talk about it all week. It's I know from myself, like I've been practicing for like 6 years. This is my 6th year now, and I feel as though I was speaking to one of our sports doctors about this week. I feel as though throughout your career, you just go through ebbs and flows of what you do and what you don't do for plantar fasciopathy, and you sort of go through phases of oh, I'm doing this really well, and then you go through a period of this is really frustrating me. Like, what am I doing wrong? And I don't. Hopefully that this course that we've produced is gonna just settle some of that for some people and give you a bit more confidence in making decisions. And I know myself personally at the moment, like I've had a lot coming in, and I'm just some of them I'm just really struggling with, and sort of forces you to sort of maybe go back to basics of getting your diagnosis right. So that's what we're going to go into with this podcast. So do you have anything to add to that before we begin?
Well, not a profound amount, but I do very much agree with you'll find that you might be kind of in one flow with what you're doing and it's working with that lot of presentations that you're seeing. But yeah, then you'll get another run of a different client group or different set of patients, and yeah, things aren't working. And it's very easy for us to forget that it is such a multifaceted pathology with so many risk factors, so many people, like diverse cohorts that it can affect. And yeah, it really influences. If we kind of forget that initially, it has the flow-on effect as we're going through the treatment process that we may miss the key bits of information that actually lead to the positive treatment outcomes and avoid that frustration that we'll often feel.
Yep, 100%. I'm keen to get into it and throw some juicy ones at you. So first question, given that plantar heel pain can be so complex, with multifactorial things that you just spoke about, like where do you feel is, if there is one, where do you feel is the best place to start when someone first presents to you? And I guess what I mean by that is, what information do you need to know? Are there some key things before you dive into a treatment plan?
Yes, there definitely is. Good question.
No rambling allowed.
Okay, so it's definitely because, so two of the main things would be the immediate and long-term activity history, because that will sort of dictate where the next steps in the process go. And so what I mean by this is we can have, if we think back to the sort of different populations or client groups that plantar fasciopathy can affect. So we may have the active population or the older and or sedentary populations. Now, so with that, if you've got someone who's quite active, they can have, their presentation might be different. So they might have a long-term history of a high amount of activity, and then their acute or more recent activity history, that's relevant. Whereas if we're looking at someone who's quite sedentary, regardless of their age, it might be a chronically underloaded tissue that's gone through an acute overload, or we may have in an active cohort a chronically healthy tissue that's gone through an acute overload, or it's a chronically overloaded tissue. So the long-term and the short-term activity history, I feel that's the most important place to start, regardless of how long the symptoms have been around for. Symptoms are relevant, but that will give you an indication on, again, if you're dealing with a healthy tissue that may have been experiencing an acute overload, or a chronically underloaded tissue that's gone through an acute flare, if that makes sense.
Yeah, it does. So you sort of look at the acute to chronic workload ratio, I guess you could. Is it somewhat related to that, or is that different?
It's a similar way to look at it, but it would be very different. So when we're talking about the acute chronic workload ratio, that's still more recent, but because especially with pathologies of chronicity, so Achilles tendinopathy, plantar fasciopathy, the tissue changes. It can be sort of an underlying pathology of chronicity that people aren't aware of at the time that they're heading towards. And it might be years that it's been bubbling away under the surface until they reach that threshold for an active or reactive pathology. So similar approach, but the time frame might be considerably different or longer.
Yep. So activity history, short term and long term.
Yep.
What else? What else is important to know?
It would be, then you start to look at some of their other risk factors that might be at play. So them as a person. So the other risk factors that you'll look at. So we've got, okay, so we've explored their activity history, and then, okay, what other factors may be feeding into the problem? So this is where you would be honing in on probably the situation or the circumstances surrounding the more acute flare of the injury, right? So what have you been doing in the time around and the time preceding symptom onset? So this is where we explore more in depth their recreational activities, their occupational activities, their footwear, any changes in activities, any life stresses. So it's, again, step one is more so the chronic and acute activity history. And then we start to hone in on the risk factors that might be relevant to that sort of acute phase. And again, when I say acute phase, you may even look at it sort of 2 to 3 months prior to symptom onset. So when I say acute in that sense, it's not like an acute injury onset, it's the more immediate time frame surrounding when symptoms presented, if that makes sense.
So that's when you would ask, like, have you put on weight recently? Have you worn different shoes? Has anything in your job or your exercise changed in the last few weeks since this has flared up? Like, you're looking for very obvious signs of what might have caused this, so to speak.
Yes, definitely.
Yeah, cool. Anything else on top of that?
Well, maybe not so much what's on top of that, but why that's relevant is because it starts to trickle down into what we may then need to assess. So it's the activity history, because this is where we start to think about the calm things down, build things up. So for someone, if they're in that more chronically either healthy or chronically overloaded active individual going through an acute flare, they may be a calm it down and the approach may be more load management related as far as activities go. Then for someone else, if it's a chronically underloaded tissue, it may be more calming down initially, but then actually needing to build things up. And what we need to do to build things up in the active versus sedentary client groups is quite different with our long-term management approach. So it's, again, the risk factor exploration is quite important, because that will start to give an idea on if we're dealing with more of a tensile driven pathology or a compressive driven pathology. And again, that will also subsequently alter what functional or physical assessments we perform in the clinic to help hone in our immediate treatment.
Yep, 100%. And that gives me a great next question for you. You mentioned compression versus tension on
Yep.
the plantar fascia. So what's the difference? Like, just in simple terms, what's the difference between compression and tension? And how do you tell which one is more of the driver in the pathology? Can there be both? And then what does that tell us that we need to do?
Good question. I like this. Okay, so to answer the first question, as far as can it be both? Yes, you can definitely have a concurrent presentation. But when we're dealing with, and so first up, sort of I'll dial it back a little bit, especially when we look on social media and even our beliefs as clinicians, it's very easy to forget that compressive factors can actually drive the development of pathology. How most people see the development of plantar fasciopathy is a tensile driven pathology. So we're just thinking that the arch is sort of flattening or dropping, and we've got this tension or pulling on the plantar fascia that will contribute to the development of the pathology, which it can. But where we've got the heel and then the plantar fascia inserts, when we've got the ground reaction forces, so when we're actually putting our heel to the ground, the enthesis or the origin of the plantar fascia, that's actually subject to bending forces. So you've got all this ground reaction force coming up, and then it bends the insertion of it, because with the insertion, it's more of a fibrocartilaginous insertion point because it needs to be strong and reinforced. It's much the same as where our ligaments attach to bones, where our tendons attach to bone. It's got some fibrocartilage there because we're transitioning from soft collagenous tissue into an osseous insertion. So with that, we have, excuse me, so compressive factors can actually be a big driving factor. Now, with this, there's a couple of things that will hint towards if you are dealing with more of a compressive and or tensile driven pathology. And often we may not know for sure, and again, often there may be a concurrent presentation of both. You may have tensile and compressive elements, but identifying what the not most likely driver, but the driver of the most important symptoms or relevant symptoms at that point in time is quite important. So to give a little bit of an idea, so paying attention to what they say, so the symptoms that they report, and also considering their risk factors and just their physical and clinical presentation. So if you've got someone who is a little bit older and or may have a higher body weight or increased body mass index, and the sort of threshold for the risk factor here is a BMI over 30. So especially if we're older, that may be a bit more of a compressive driven one. If we're a little bit overweight, then again, that may contribute to a little bit more of a compressively driven pathology. And then our activities, either recreational or occupational. So are we spending long periods of time standing on hard surfaces or walking on hard surfaces? And then, so they're the risk factors that will give us a little bit of an idea of what we may be dealing with, and then how they say it. So if people are reporting that it feels like they're walking on a stone bruise, or if they're wearing shoes that are a lot more cushioned and comfortable, or if they feel like when they're walking around at home on carpet versus on the tiles, it's significantly more comfortable, then chances are that's a bit more of a compressively driven pathology. Again, there can be a little bit of a crossover. But then with tensile driven pathologies, oftentimes people, if we're asking about what are the symptoms, what do you notice, it may be that initial sort of when they first put their foot to the floor, that kind of pulling sensation, and then it warms up really quickly after a couple of steps. Or if they report, oh, when I move my foot into this position, and often if it's moving into sort of the toe off position where we've got the digits dorsiflexed, that may be indicating that it might be more of a tensile driven pathology. And again, you can have both, but they would probably be some of the flags that I'd pay attention to initially to give a little bit of an idea on what we're dealing with.
Yep. No, that makes sense. I got a question for you to follow up.
Mhm.
What I tend to do in clinic, or what I've started to do a lot more, is when I'm asking someone about their pain when they're walking, for example, we might be doing a gait assessment. I ask them, do you feel the pain is more when your heel hits the ground, or is it as you come over and push off through your toes?
Yep.
Um, is that specific or sensitive, do you feel? Or obviously probably hasn't been validated, but yeah, that's what I like to do. And also with calf raises as well. If someone's loading up with a calf raise, you may have them doing a plantar fascia calf raise with the fasciitis fighter or a towel, and they're coming up onto their toes all the way through the concentric, all the way through the eccentric. There's no pain, but when their heel hits the ground, there's pain. So that tells me that it's probably more of a compressive injury more so than tensile. Again, don't know how valid that is, but that's just something I've found in clinic. Would you agree with that?
Yeah, I definitely agree with that. And to hone in on your point, yes, it's with a lot of things, they haven't been studied, therefore they can't be validated. But then that's what medical and health practice is consistently evolving or constantly evolving, because we still know that there is so much that we don't know. But it's one of those things that, yeah, if there's smoke, there's fire. So if someone's reporting something and it's consistent with other patterns or symptoms that we're aware of, then it's a best guess that yes, that is likely what we're dealing with, which, yeah, it hasn't been validated, but they do appear to be somewhat, well, at least in my experience, or anecdotally, self-reported symptoms like that and responses to certain functional movements and functional tests, I feel it does correlate quite well. But
Yep.
again, it hasn't been validated. So, but I do use their self-reported symptoms with certain movements, exactly like you were describing, to help give an indication of where they may be sitting on the compression/tension scale.
Yep. No, that's good. Good to know. I could be a bit more confident with that now. But I guess if we then get a bit more of an understanding as to whether it's a compressive versus a tensile issue, um, to load or not to load. So from a rehab point of view, and from there, we're probably thinking of like your plantar fascia loaded calf raise as an
Mhm.
example. But there's a whole range of different exercises you could do.
Yep.
So whether it's compressive versus tensile, do we load, do we not load? And then the follow-up question from that will be, how do we use orthoses for whether it's tensile versus compressive? So we'll start with the loading first,
Yep.
and we'll go from there.
Yes, that's good. And this is again why it's very important for us to assess their activity history and then their risk factors, and then have a little bit of an idea, even if we're not 100% correct, but have an idea of what the primary symptom or most relevant driver is. Because yes, if we think that, so say we've got compressive and tensile. Now, if we think back to the client that I was sort of describing, we've got an older and overweight client. So we may have, in that presentation, they may have a little bit of a concurrent pathology, but the primary driver identification is quite important, because if we've got someone who is chronically underloading, so they're not really active, they're not walking regularly, they're not engaging in a lot of physical activity. So they may have some structural alterations within the plantar fascia that makes it less tensile load tolerant. So they may have that underlying load intolerance, but also because of their age and their body weight, they may have changes within the plantar heel fat pad that is actually making it more of a compressive driven pathology. So they may have both concurrently occurring, but the primary factor may be compressive. Now, if it's compressive, and then we don't sort of factor that into the equation and we just jump straight into doing some rehab exercises, that may actually flare the symptoms, because we've got the primary driver that we haven't addressed. So we haven't been able to calm down the pain in that situation. So the compressive factor is still sitting there. And then if it's tensilely driven and it's just chronically load intolerant, but then we apply some load with, say, the high load strengthening of the plantar fascia, those exercises, then we may actually overload that tissue as well. So then we've redlined both pathology drivers, if that makes sense. So if it's more compressive, and this is where our treatment triage comes into the equation. So you may be introducing some exercises, but I would, if it appears to be a little bit of both, but it's probably more compressive driven versus tensile. The tensile is just sort of a subset of all their other risk factors. It may be going with a very, very, very low dose of tensile loading exercises. So say like even just the heel rocker exercise on the fasciitis fighter, but then focusing your initial treatment on the compressive elements, which may be footwear, considering the surfaces that they're walking and standing on either at work or at home. And then for the slow burn, as far as long-term management, it may be trying to address some of the other health-related factors. So if it's more compressive-driven pathologies sometimes don't need any physical rehabilitation at all, simply calming down the tissue, because they may have relatively healthy tensile tolerance, but it may just be more compressively driven, or it may be chronically underloaded in a tensile state. Either way, I would, if it appears to be more compressively driven, you focus on the compressive treatments and then cater to the tensile tolerance if you need to. But then if it's more tensilely driven, then it tends to be more focusing around the activities that they need to do or shouldn't be doing or should be doing less of. So if it's more tensilely driven, yes, they may have an intolerance to tensile load, but then this is where it's important to consider their chronic or very long-term activity history and their short-term activity history. Because if you've got someone who's chronically underloaded and then has just experienced an acute flare, they'll likely need some low-grade exercises that we gradually progress them up to changing their lifestyle and health behaviours for the long term to introduce ongoing frequent bouts of loading so they can build their tolerance. But then if we've got someone who it's quite a healthy fascia and then they've overloaded it, so they've rapidly increased their running loads, then it may be more tensilely driven, but their management plan may actually be reducing the load or taking movement out of the equation for a short period of time. So does that help answer that? It's a long-worded answer, but does it help sort of give you a bit of an idea of where exercises may fit into the different drivers and what our considerations are?
It does. And I think it's just really what you're trying to say is it's just very important to take a really good history. It's a really good subjective history of all of their lifestyle factors, all of the contributing factors that might have caused this pain, and then identify whether there's a capacity gap that needs addressing, whether they need to start loading their plantar fascia. I think it's fraught with danger if we just get someone with plantar heel pain and we go, oh, straight away RAF left protocol, straight into loading them up. Plantar fascia loaded calf raises. I think that study was fantastic and sort of introduced loading into a lot of podiatrists' arsenal of things to do. But it's important that we don't just rush to that, because if they've had an acute flare up of pain from doing too much, then if you're adding extra loading on top of that, then it's not gonna help. It's only going to make things worse. So does that sound about right to summarize there?
Yes, and then I'll say it's a good summary. I very much agree with it. No, yeah, you took my 8,000 words and put it into 2 sentences. But then it's not just with the exercise therapies. It's if we're jumping the gun and missing the relevant information, regardless of the treatment that we follow. Like there's some clinics that I know of that literally on the first consult, they're booking people in for 3 sessions of shockwave, regardless of their clinical history. It might be a runner, it might be an older person, it's shockwave, then orthoses, and then very little time is taken. And this is just speaking to my experience with some of the patients I've seen that have seen clinicians that have gone through this sort of protocol. And it just seems like hasn't been much time or attention paid to activity history, risk factors. That's been skipped and just flown into the protocol that exists within a clinic. And can be different for everyone and anyone, but going into shockwave, going into orthoses, whatever it is. And that's where you end up with patients that have a lot of frustration and losing faith in health practitioners, not just podiatrists. It exists for physios and chiros and other health practitioners, when it's not having the treatment that's being tailored to their individual driving factors.
Yeah,
And
I
then
feel
they're
like
having treatments that may be inappropriate or ineffective for what they actually have going on, and it can flare the problem.
yeah, 100%. I feel like shockwave therapy is going to be a whole. I was going to ask you a follow-up question about shockwave, but I feel like that could be a whole lecture, a whole podcast episode in itself.
Yep. All
Diving
right,
into.
we'll put a pin in that one.
Leave that one for now. But yeah, no, 100% agree. Really important that you get really good subjective history and then let that guide what you're gonna do, and reflect on that. So I like, if I'm doing something for like 3 sessions with someone, or let's say, for example, 3 weeks. Often I see people sooner than that, but let's say I'm seeing someone over 3 weeks for 3 sessions, and then if they're not improving, or in some degree, it may not be that their pain's improving, but if their function or their strength's not improving, like I'm flipping over to try something else. Like, I feel like you need to reflect on your treatment plan and what you're doing, as you're going. And then if you're, say, for example, if you're doing shockwave for example, three sessions of shockwave, and then that doesn't have any improvement, then stop doing shockwave.
Yeah, do they really need another 6 sessions? Probably
Yeah,
not.
that's right. But same as with the loading. Like if you're loading them up, if you're doing a plantar fascia loaded calf raise, and they're working through it over a course of 3 weeks, but their pain's just not improving, then you need to consider, well, what else is happening here?
Yes. And to talk to your point that you mentioned briefly, is it's not just pain, it's focusing on function as well, because especially in those pathologies of chronicity, sometimes pain can be a little bit slower to dissipate. So we may improve in function quite quickly, and then improvements in pain may come a little while after. But that's why I feel it's always important, especially right at the start, and I think we've spoken about this on a couple of podcasts, is always having an overarching treatment goal in mind. So right from the onset, what are we looking to achieve? And then that's where we sort of identify the capacity gap. So we have the desired capacity, so what activities they want to get back to that the problem's stopping them from being able to do. So that's a desired capacity. Then we assess their capacity. What can they currently do in relation to that? And then that identifies the capacity gap. And then that's where our treatment plan formulation comes into play. Okay, how far removed are they from this? How many steps may we need to get there? So that becomes the macro overarching goal. And then the micro goals of what we're looking to achieve between sessions or in the shorter term. So it may be improving the number of repetitions in the high load calf raise, or the amount of minutes that they can run before symptom onset. So I just wanted to reflect back on that, because goal identification is very, very important. And I feel that's also one of the missing pieces of the puzzle when you have these patients that are seeing practitioners, having treatments that may not be helping them. And because if we're not constantly sort of reviewing where we are in relation to our goals, that's where our patients just get frustrated. They cancel their appointments. They don't come back because we've kind of lost sight of what we're actually working towards.
Yep. Makes sense. So we've gone through compression versus tension. We've gone through whether to load or not to load. And the last one we'll go through now is orthoses or no orthoses. I feel like the 3 of these topics are sort of all intertwined. One sort of leads to the other, potentially. So let's tackle orthoses. Where do we start as to deciding whether someone needs them, doesn't need them? Does anyone need them? Does everyone need them? Let's go through it.
Let's Pandora's box this. It's quite there's a lot of nuance to it. So we'll start with, does everyone need them? No. Do some people need them? Yes. And then the type of device that they need, that can vary between individuals. And so when I talk about it again comes down to if there's a capacity gap and if there's potential for this capacity gap to be perpetuated by a person's orthomechanical profile. So orthoses we can use as a load management device, and so they can open up the sort of therapeutic window for having someone to be able to engage in more activities. So if we've got someone that orthomechanically we need to overcome a barrier. So orthoses can be scripted to address either of the pathology drivers, compressive and or tensile, or both. So then I think where we start to begin to think where orthoses may come into the equation is if we think about the compressive drivers first. So does the person have a thinner fat pad? Do they have fat pad dissipation or spreading when they're weight bearing? If that's the case, then they may need an orthoses, because like cushion footwear and changing the surfaces that they're standing on, so rubber mats at work, that can help. But it still may, because if the fat pad's still dissipating within the shoe, and shoes, they lose their responsiveness and cushioning over time. So if we have someone who a thinning or dissipating fat pad is a primary driver for what we consider to be a driving factor for their pathology, then they may need an orthoses sooner rather than later with a really deep heel cup, try to compress that fat pad, limit the dissipation. So orthoses for a compressive driven pathology may come into the equation much sooner. But then on the flip side, if we've got someone who it's, say, more a tensile driven pathology, they may not need an orthotic device, because there's so much of the tensile driven pathologies that we can overcome with exercise and functional restoration. We can modify loads with footwear. But if there continues to be a capacity gap, so we know that orthoses, they do decrease the tensile loads on the fascia, and they can decrease the bending moments at the plantar fascia origin. So if we can't get them over the line, and there's a little bit of nuance to this, which I'll jump to in a second, but so compressively driven ones might come into the equation a bit sooner, because a lot of those factors we can't modify as much. But if it's more tensile, we've got a lot more wiggle room for tissue adaptation to try and overcome that. So we may try exercise therapies first, load management, we may change footwear. If we find that with all of those, we still have some degree of capacity gap, then we may introduce orthoses. And these are general rules, like it does change for each patient, which it should change for each patient. But I tend to find personally that for tensile driven pathologies, orthoses will come into the equation much later, because there's so many things that we can address that may negate the need for an orthoses prescription. But if we do find, so what I'm talking about, if a capacity gap remains, so let's say we're dealing with a runner. So when we're running at different running speeds, it does change the tensile loads exerted on the plantar fascia. So if we've reached a ceiling of adaptation, so someone might be able to only run at, I don't know, a certain running pace and their symptoms are fine, but every time they try and go above that, even with a progressively loading run exposure program or plyometric training, whatever exercises we're prescribing, if they're constantly reaching this ceiling of adaptation, it doesn't matter what we're prescribing, they just continue to have a symptom flare when they're trying to run at faster speeds, then we may introduce orthoses into the equation to help manage the tensile loads during running for that individual. So it's a very nuanced answer. It really depends on the clinical presentation. And then again, the orthoses script varies depending on the pathology driver or if there's the concurrent drivers.
Yeah, 100%. I like to think about what have they done so far as well. Like they might have been to see other clinicians and they've tried all sorts of things. They might have been given some crappy little device from somewhere, like some sort of prefab device that wouldn't even suffice for anything. But then so then if they haven't tried orthoses before and they've had chronic symptoms for a long time, well then yes, they introduce an orthotic to try and sort of kick the pain in the guts a little bit. But then if someone comes in and they've just had an acute flare up, if they're an athlete, if they're a runner, for example, and they've just had an acute flare up of pain because they've increased their mileage or their intensity of running, then they haven't had orthoses for 30 years. Why do they need orthoses right now? Like you got to, and I've made that
100%.
mistake once in like my first year out. I had a patient come in to see us, and he was like a ultra like marathon runner, and he had plantar fasciitis, and I just recommended a orthotic because taping helped. So I was like, oh, an orthotic would help. But then I realized he's been doing this intense mileage for so long. His capacity is so high already. He's just had a sudden increase. So yeah, he doesn't need an orthotic.
Yeah, that's a learning experience for us. But in saying that, there are some people, so some nuance to this, because I've made that mistake too, but we learn. Hopefully we learn. But in saying that, because and this is that point that I alluded to before, is that sort of patient-informed care, so giving them the option. So we'll use that example of your patient that was the ultra runner. So if we know that the taping helped and it sort of decreased the load so they could get back to their training loads a little bit quicker, a patient may opt for that. So
definitely,
you don't
100%.
have to hold off prescribing orthoses. If there's an avenue that the orthoses may help and it might get them back to their activities sooner, we can give them that option. And I think giving them that option instead of force feeding it down their throat for profit margins is important, because there are some people that like being able to run consistently is their life. Like I know for me, I go insane if I'm not able to exercise most days. So if it's okay, you've got XYZ because we've considered all of their activity factors, their risk factors. Okay, so, and the strapping helped alleviate it. We could take the option of like you strapping your feet every couple of days. You may need to do this for a few weeks whilst we reduce your load and work on this. Or some people might go, is there another option outside of strapping because I can't be bothered? I have an allergy to tape, all of these other factors. We can go, well, an orthotic device might help you short term to get the pathology or the pain under control, and then we reintroduce load. So it's, I think it's a good example that you used, and it's the only difference, that there would be, which I'm certain that you would have learned from. So instead of it being the clinician's go-to recommendation for treatment, it may have been just a clinician's recommendation for a treatment option.
Yep, 100%. Yeah, give them the options, like that. Let them make an informed choice as to what you're going to do. Yeah, I love orthoses. Definitely not bashing orthoses. I love prescribing them. I feel it's a real art and science as well. But definitely just got to consider all things and have that discussion with people. If you feel as though they could benefit from an orthotic, then sometimes you're not really doing your job well if you don't offer it as an option, because they could benefit from it. Definitely, at least bring it up in conversation as being a possible option, and explain why you're perhaps not leaning towards it right now, and then that can pre-frame them in, say, a couple of weeks' time. If things aren't progressing, you can be like, okay, well then, we may want to consider an orthotic now. I think it's a bit iffy or almost rude sometimes to bring up the orthotic as an option 3 or 4 weeks down the track if you haven't mentioned it previously.
I agree, and that's a very good point. I think, and that's one of the things that if we kind of lean on Matt Kotchett's work, where it's I can't remember the title of the paper. I should remember the title of it because I refer to it so much for the course. The key elements for quality care, specifically to plantar fasciopathy, and like one of the reported things that patients want is an understanding of the different treatment options that are available to them. So I think, at the onset, we don't need to go list every single thing, like ultrasound therapy, because that doesn't work, laser therapy, dry needling, all of these things, but the evidence-based treatments that will potentially work and are relevant to their clinical presentation, giving them a little bit of an outline. And it also gives you a bit of a buffer as far as expectations instead of,
Correct.
so if we try one treatment option and then we're not getting the outcome, sometimes a patient may not come back because they go, oh, well, they gave me this one treatment, it didn't work, therefore they're useless. If we go, okay, these are the potential treatment options that may help your clinical presentation. It may be orthoses, exercises, changing footwear, load management, whatever it is. Okay, but the reason I'm recommending this and this first is because of your presentation, and this will likely get us over the line. But if that doesn't work, or this might help accentuate or fast track the process, we may introduce orthoses or changing shoes or getting a second pair of shoes. So yeah, I agree with you that giving them a little bit of an idea of what all elements of their treatment may focus on, or may become part of their treatment throughout the whole treatment journey, is a good approach initially, but then explaining to them the role of the treatment and then what you're leaning towards initially. And because it gives you a buffer, because if they know, all right, we're going to try these two things, but if that doesn't work, Jackson or Talysha knows that, well, they've given me these options, that there's also option B, C, and D that we can try. So all hope isn't lost if things don't go to plan in the first or second session.
Yep, 100%. I think it's just a skill in communication, and you'll develop it with experience as well. And yeah, there's so much there that we could unpack. Like, I feel like there's definitely a part 2 here somewhere that we could go into plantar heel pain again. But I think that's a really good summary, like some key points of what you need to know, compression versus tension, to load or not to load, and then where do orthotics come into it as well. How would you like to summarize yourself, Talysha? Because you've gone through quite a fair bit there. Just a few key points for us.
I reckon the best way to summarize it is we've got a free resource that I've created I call it the Plantar Fasciopathy Rehab Guide or Rehab Decision Tool. And it's literally a framework I've stepped out that follows the steps of what we should be asking, what we should be considering, because I think that will revisit or allow people to revisit this entire podcast episode really, really well and have it stepped out in a process. But to summarize, when we're dealing with not just plantar fasciopathy, but any presentation or musculoskeletal presentation, it's always important to start with getting to know the patient. So the subjective history, their activity history, exploring their relevant risk and health factors. That's where we need to start, because if we miss that information at the start, then it can set us off down the completely wrong treatment path. And that's what leads to wasted time, wasted money, patient frustration, patient attrition. And it's just not good. So if we go back to basics, ask the right questions, that will set you up for being able to develop your really individualized, goal-orientated management plans. That there will always be instances where things don't go to plan in musculoskeletal rehab. That's the nature of the beast. But the more time we take initially to be considered in our approach relative to the individual, that's how we set ourselves and our clients up for success long term.
Yeah, do away with protocols. You can have frameworks, but everything needs to be clinically justified.
Yes, that's an even better summary. Summarize my summary.
There we go. Well, if anyone wants to find out more about that course, which we've just launched this week, head to, again, progressivepodiatryproject.com/PF Masterclass. Really looking forward to delving into it myself a bit deeper. And it's going to answer all of these questions that we've gone through in a lot more detail as well, and be really more help to give you a bit more confidence around treating plantar fasciopathy. So yeah, thanks again, Talysha, and we'll catch you guys at the next episode.
Awesome. Thanks, Jackson.